Hello everyone. Today is the 21st APASL webinar. APASL Episode 3, Session-7. Today we have two sessions. One session is initially Professor Ming-Lung talk. Ming-Lung Kaohsiung Medical University, Kaohsiung, Taiwan. His topic is the latest situation of COVID-19 in Taiwan. Professor Yu, please.
Okay. Okay, good day, ladies and gentlemen. Professor Salim, Professor George Lau, my friend Professor Kanda, and dear colleagues in the website. Today, I would like to take this opportunity to share you the latest situation of COVID-19 in Taiwan. I will share a brief introduction. I think I need only 5 minutes. So far, there are around 30 million people are affected with the COVID-19 globally, with nearly 1 million people die with this COVID-19 infection. The mortality rate is around 3.14%. We are lucky that we live in Taiwan. From January to yesterday, there are only 503 confirmed cases of COVID-19, including 7 days with a mortality rate of 1.39%. So this figure show the total cases that's presented with suspicious symptom sign of the COVID-19 in the past 8 months. It's around 91,000 have been reported with suspect of COVID-19. So with a total test of the COVID-19 and the testing of around 185,000, most of them were excluded from the COVID-19 infection. So the confirmed cases, it is just only 503, and 478 patients have recovered from the COVID-19 infection. So as you can see, right now there are around 600 to 700 people will be reported as suspicious of COVID-19 infection, but it's only around 2 to 3 cases will be confirmed as COVID-19 infection. So this slides show you the distribution of the imported cases of COVID-19 in Taiwan. As you can see, most of the cases confirmed infected with the COVID-19 come from overseas. 448 patients. The leading imported area is United States, Europe, and the Southeast Asia. There's still some cases are recognized as indigenous cases. It's around 55 patients. Most of them live in the northern part of Taiwan, including Taipei City, New Taipei City, and very rarely in the rural area. So why Taiwan have such success in the fighting against the COVID-19? It is because that Taiwan has implemented a lot of pandemic prevention policies so far and very early. And I think it's the earliest one, the first one countries to implement the border controls and the mandatory quarantines and health management and mass ration plans. And also the government of Taiwan advocate the people should change their lifestyle under the slogan of Epidemic New Life movement. So every people in Taiwan are encouraged to wash hands, and every people, when they enter any indoor activity, there should be we have to measure the body temperature, and we advocate that everyone should wear mask in public. And also it's very important policy to keep social distancing 1.5 meter for the indoor activity and 1 meter for the outdoor activity. And also we implement the real name system. So if we find a confirmed case, we can link to the contact persons very quickly. So to advise the persons who have history of contact the confirmed cases to keep the safe health management. And also we advocate the every institution should clean and disinfect the environment regularly. So here is the real world scenario in Taiwan right now. As you can see, almost all the daily activity is allowed, even the concerto. But people are asked to wear mask during the entire activity, and almost all the every building have the body temperature equivalent, as you can see, and also every hospital have a very strict regulation for the patient or visitors. So we are lucky that we live in Taiwan, so that we just a little bit, we just affect by the COVID-19 only with a little impact on our daily activity. So let's fight against the COVID-19 together. But I think it's need at least 6 months or 1 year before the introduction of vaccine. Thank you.
Thank you, Professor. You nice talk. Is there any question from audience?
Professor Yu, this is a very important talk to all of us, because in most of the world, a lot of measures has been implemented and life is made intolerable. So all the social activities, so all the economic activities, and just wonder whether this really worth sometimes, not just for entertainments. All our restaurants are closed at one time.
Already.
And no gathering for more than 2 people. There is no golfing, no tennis, no swimming pool, no beaches. And well, I mean, well, what is your opinion on this? Because then now we are facing the 3rd wave in Europe, and I just learned from CNN that UK needs to lock down again, and apparently this time this is not like something like SARS, which goes away. So, what is your opinion on the balance between the control of the infections and all the social measures being taken? Because life has to go on.
I think there are cultural difference between the West country and East countries. The people in West country, they believe the people rights is the most important. But in this COVID-19 outbreak period, I think everyone have the responsibility to take care of themselves to avoid to be infected or to avoid to spread the COVID-19 to the others. So people in Taiwan follow the government rule very strictly. For example, for the residents come from overseas, we have to have 2 weeks self health management. It means that we cannot contact even our family directly. So we have to live in our house for 14 days and cannot go around. If we go around, we have to wear the mask all the day. So I think just only a little a restriction of the daily activity for 14 days, it will make the society more better. I think it's the very important one is the people have to follow the strategy, policy, and the regulation of the Taiwan CDC, the CDC of each countries.
Professor Ming-Lung, I have 2 or 3 questions.
Okay.
Do you or your country does antibody screening for people in the general population?
Yes. Just last month, we have a Zhanghua County Department of Health in Zhanghua County just complete around 8,000 screening of the COVID-19 IgG antibody in the general population. So the zero positive rate is just only around the 0.2 to 0.5%. So it's not more than the rate of false positive. So I think so far there are no community spreading in Taiwan.
Oh, very important. In India, the antibody positivity rate is in New Delhi is like 33%.
Oh,
33%. So there is a very big fear of our population being silently exposed. The second question I have of reinfection. In India, 4 cases they have reported where a different mutant strain has infected. So any experience in Taiwan?
No, because there are only few. We only have 500 cases. So far we didn't observe any reinfection patients.
Any experience of liver patients who have cirrhosis and got COVID, SARS-CoV-2?
No, just only a patient with chronic liver disease, hepatitis B. Just on that, but the patient is under the NIC therapy, so there are no any LT elevation in this patient.
Very nice lecture. I hand over to the chairperson, Professor Kanda.
We have 2 questions from audience. One is, how about your opinion about vaccination? Can't we manage better with vaccination?
I think, for my opinion, I think it's very difficult to develop effective vaccination within 1 year. I think it's very difficult within 1 or 2 years. Yeah.
Thank you. And another one question: how's the role of social media in COVID stopping spread in Taiwan? The role of social media in Taiwan?
Oh yeah, actually the Ministry of Health and Welfare, they used to hold media press every day to publish the status of the COVID-19 infection in Taiwan every day, and also to announce the every new strategy. So I think it's very important. Well, not only social media, but all the media. So every resident in Taiwan know very well how we have to follow the regulation of the government.
Thank you very much. Thank you. Nice talk, Professor Yu. We move on to the next session.
Okay. Dear guys, in the next session of this webinar, we are very happy to have Professor Arun Sanyal from Virginia Commonwealth University. Actually, Professor Arun Sanyal is a very well-known specialist in chronic liver disease and its outcome. He is currently the Executive Director, Education Core Clinical Center of Translation Research in Virginia Commonwealth University. He also serves as a chair of the NIH NASH Research Network and is the current chair of the liver study section at NIH. He is the academic and steering committee co-chair of the liver forum. And he has published many important papers, especially focused on the non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. So today we are very happy to have him to deliver the second talk, the drug development for the NAFLD and NASH. So ladies and gentlemen, please welcome Professor Arun Sanyal.
Good evening, everyone. My name is Dr. Arun Sanyal. It's a real pleasure for me to speak to you today about drug development for NASH. Here are my conflicts of interest, and these will be available with APASL as well. So the past year has been quite busy for the field of NASH, and many drug trials have read out. Unfortunately, there is an increasing number of drugs that have failed, and this list keeps getting larger every year. But on the other hand, there are also a few studies that have read out positive and continue to move forward for drug development. So my goal today is to talk about some of the lessons that we have learned from these trials so that future drug development efforts are more successful. So the key takeaway from this lecture is that successful drug development depends on you having the right target and to connect that target to the right population, to have adequate safety, and then ultimately right efficacy. So if you meet all of these in a systematic manner, you're likely to have a positive outcome at the end. So let's go through these and see where some drugs worked and some didn't, and what can we learn from this process. So over the course of the last 15 years, a very large amount of information has become available that shows that the progression of NASH follows a 4-step process. The first step is a metabolic overload of the liver, which manifests as hepatic steatosis, which is a surrogate measure for widespread metabolic overload of the liver. This overload leads to cell stress and cell injury that, if severe enough, can lead to apoptosis and cell death and trigger an inflammatory response. Continued inflammation leads to progressive fibrosis, which then leads to cirrhosis. Of these, the upstream elements, that is steatosis, injury, inflammation, are considered markers of disease activity, whereas the fibrosis is considered a marker of disease stage. And this has, of course, provided us our current approach to how we attack NASH for therapeutics, where each of these different buckets can be attacked separately or in combination. Now, a key process to learn over here is that if you look at this in terms of the metabolites and the cell signaling that is involved, starting at the top with metabolic overload, leading to cell stress, then inflammation and fibrosis, what we see is that as we move from the top down to the bottom, the number of signaling pathways and mediators continues to grow. And therefore, if you attack only a single target downstream, when there are many pathways that are leading to fibrosis, that may be insufficient unless you hit a nodal target that shuts off the entire process. So the best results are seen when you go upstream in such as weight loss, bariatrics, pioglitazone, FXR-FGF19, GLP-1s, etc., all of which target the upstream root cause, which is the metabolic overload of the liver. So the first lesson is that sustainable therapeutics have to be anchored on identification of key nodal targets or combinations. In the absence of such identification, treating the root cause is the most de-risked approach for pre-cirrhotic NASH. Next, let's talk about the correct patient population. Currently, we know that as NASH progresses, fibrosis tells us how close somebody is to cirrhosis. And once you get to cirrhosis, then you start experiencing liver-related outcomes. So liver-related outcomes virtually entirely occur after the development of cirrhosis, whereas cardiovascular, renal, and cancer-related mortality is seen throughout the course of the disease. So for drug development, we usually target people who have NASH with stage 2 or 3 fibrosis, or people with cirrhosis. Now, for patients who have stage 2 or 3 fibrosis, we are trying to prevent cirrhosis. On the other hand, for people who have cirrhosis, we're trying to reverse their cirrhosis. So in this process, one of the things we have learned is a big issue with placebo response. Across different trials, we see quite variable placebo responses. And in many instances, an unexpectedly high placebo response has led to the drug not being considered to be effective. So if you look at a decrease in disease activity through a reduction of the NAFLD activity score or even the SAF, about 20–25% of patients show this. And if you break this down, what you see is that it's not just a matter of the fat. You see almost a third of the patients show decrease in ballooning, inflammation, and up to 20% of patients may actually show a one-stage fibrosis improvement. And this is reflected, of course, and this occurs even when you're doing early phase studies and looking at intrahepatic triglyceride and liver enzymes. So there are some lessons to be learned here about how to minimize this risk. First of all, lifestyle recommendations should reflect common sense and what is current practice and not idealized intervention. So if you have a trial run at multiple centers, where at one center, people become very conscious of their NASH and insist on very rigorous lifestyle intervention, whereas another center does not, you will create heterogeneity, which may create problems. So there is currently a lack of science-driven consensus on what lifestyle interventions should be made in this setting. The overall quality of the literature is poor, and the need to balance what is ethical in terms of providing healthy advice versus creating an intervention in and of itself that is unproven in the long term, I think remains a conundrum in this race. The next lesson is that we often hear in many meetings that if you just lose 10% weight, everything will be good. So let me show you over here that if you look at resolution of steatohepatitis, there are at least a third of patients who had less than the 10% who also improved. Similarly, if you look at the 10% weight loss threshold, as in this shown in this landmark paper by Villagomez, of those whose fibrosis improved, 2/3 of these patients actually did not meet the 10% threshold. So your fibrosis can improve even with less than 10% threshold. And I think we need to understand the processes that lead to improvement in fibrosis under lifestyle intervention conditions far better and in more detail before we can actually use this information in the setting of drug development. So we know that unresolved NASH is associated with less than 7% weight loss, but most people with fibrosis improvement at less than 10% weight loss. The other issue that comes up is that NASH is not an isolated disease. It is a part of a multi-system disorder that involves the arteries, the heart, the pancreas, the kidneys, all of which can cause and impact outcomes. And these are all, of course, linked to metabolic stress and ultimately linked to increased adiposity. There are different treatments for each of these comorbidities, but many of these treatments may also impact the liver. So the variable use of these drugs for comorbidities can also create confounding within the studies and account for the variable placebo response. Now, if you exclude people with all of these comorbidities, you'll have a pure study, but you will also have a study that cannot be translated into real world. So any drug being developed for NASH must have enough of an effect size to rise above the background noise created by variable use of drugs for variable comorbidities across the patient population. Now, moving across to the next step is safety. The same concepts about the multi-system nature apply to safety. The patient is under constant threat of cardiac problems, cancer-related problems, and these are, of course, shown over here in the form of cardiorenal and metabolic problems. So in the setting of drug development, an anti-NASH drug must be at least neutral with respect to extrahepatic end organ disease and outcomes that are concomitantly present. So in the drug development, you have to track new onset hypertension, markers of sympathetic activation, atherogenic risk profile, measures of arterial stiffness, coronary artery disease events, need to have some track of what is happening with diastolic dysfunction, arrhythmia risk, what is happening with eGFR. If you don't pay attention to all of this, as you move into phase 3 and you're now spending a lot of money on thousands of patients, you may surprisingly find a problem that you did not anticipate. So as you go along, it is very important to collect some of these data in a systematic manner so that the safety of the drug can be established. Now, if you look at the profile of frontline therapeutics then, in terms of what we're looking for safety, we want them to be weight neutral or for them to lose weight. We want the LDL cholesterol to go down, HDL to go up, triglyceride to go down. We want MACE to go down. We want GFR to be stabilized and glycemic control to be improved. In an ideal world, the best drug is a drug that not only improves the NASH, but improves all these extrahepatic issues, which if they don't, becomes a safety concern. So if you look at the leading drugs in drug development, starting with thiazolidinediones, they gain weight. The LDL cholesterol can even increase in some reports. It is neutral with respect to MACE. Of course, it improves glycemic control. We don't have a lot of data with GFR. There are new drugs such as PPAR alpha gammas that are being developed, like saroglitazar, which is available in Asia, which is neutral on weight, very good lipid profile, but we don't really have good quality MACE and GFR data. Similarly, the FXR-FGF19 axis unfortunately produced an increase in LDL cholesterol, which requires additional intervention to manage. We do not know the effects on MACE and on GFR. FGF21 has a good effect on the lipid profile, but we do not have cardiovascular outcomes data. Same for thyroxine beta receptors. GLP-1s, of course, do not have a big impact. They're neutral on the lipid profile, but we already know they improve MACE, they improve GFR, they improve glycemic control, and you lose weight. So this is very attractive from a side effect profile. Another molecule that is being studied is aramcol, which is a fatty acid bile acid conjugate, which is neutral for weight, improves the lipid profile, but we do not have MACE data yet. So another important safety issue is drug-induced liver injury. And what this table shows are the current criteria provided by FDA on when to stop therapy in the setting of a clinical trial. And what we see now is that when you apply this to a trial that has already been completed, we know nobody got in trouble from drug-induced liver injury. We find that these thresholds have very high sensitivity, but low specificity. So that if you actually applied these FDA criteria, you would be stopping drug all the time, which creates a real problem. So this is something that more work needs to be done because the current FDA guidances and the guidance from IQ-DILI, I think, are inappropriate and overly sensitive. So one of the major lessons we learned through this process, particularly with respect to obeticholic acid, which, as you know, met its primary endpoint in phase 3, but did not receive subpart H approval, and the study is still ongoing. And that is because it comes down to benefit risk analysis. So what was shown is there was decreased activity in fibrosis, and it was believed that this would mean that it is reasonably likely that it will lead to less cirrhosis, less outcomes, and improved mortality. So this is the benefit part, but you have to consider risk. There's some pruritus, there's an increase in LDL cholesterol, but unfortunately we don't have MACE data to tell us that this is okay. And then there are rare cases of where there was some suggestion there might be some hepatotoxicity. So even when you meet your primary endpoint, you still have to establish benefit versus risk for the drugs to continue. Now, obviously, in the setting of OCA, none of these risks were really bad in the setting that if they were really bad, the study would have been stopped and the drug would have been pulled, but this is not the case. It's just a combination of benefit and risk. So the study is ongoing, and OCA still has the best profile for improvement in fibrosis of all the drugs that are moving into advanced phase, with FGF19 neck to neck with it. Okay, then this brings us to the issue of efficacy. We know there are a lot of drugs that are already being studied. So if you once again go back to the frontline agents that are in advanced phase trials, we know from phase 2 trials that thiazolidinediones may reduce fibrosis progression. The FXR, particularly OCA, has clearly shown that you can reduce fibrosis. FGF19 has clearly shown you can reduce fibrosis. We're waiting for a readout from the Falcon trials for FGF21, which will show clearly whether fibrosis is decreased. Recently at the International Liver Congress, data from Akero was presented showing that of those people who had decrease in liver fat, there was an improvement in fibrosis. Thyroxine beta receptors are very good at reducing NASH. The fibrosis signal is more modest, and I think this phase 3 trial will tell us if the improvement in NASH translates into improvement in fibrosis and less cirrhosis in the long term. Similarly, the GLP-1s, the data look very promising for the extrahepatic milieu. The semaglutide study was reported at APASL with a very high rate of NASH resolution of almost 60%. But the fibrosis improvement was much more modest. And this makes sense because these are molecules that are acting outside of the liver. They have to improve the extrahepatic milieu, which then leads to improvement of the metabolic stress that we talked about in the liver, which then have to turn off all of the injury, inflammation, and eventually fibrosis. So it is quite possible that there wasn't enough time for the GLP-1s to show fibrosis improvement. Similarly, for fatty acid bile acid conjugates, the phase 2 trials show improvement in steatohepatitis, a very modest, statistically non-significant effect on fibrosis, but this is an area that is currently being looked at. So it is very important in the drug development process as you plan clinical trials to link your approach to the mechanism of action. We already talked about the concept of activity and fibrosis stage. So in our short term, our goal is to improve activity or fibrosis. So if the drug is acting on one of the pathways linked to activity, then you show a decrease in activity in phase 2, and get the evidence for what degree of fibrosis improvement you really see to make your go-no-go decision into phase 3. In the long term, of course, you have to show a reduction in clinical outcomes, because unless you improve how a patient feels, functions, or survives, the relevance of your drug comes into question. The other thing we realize is that steatosis is actually quite important. There was a period where everybody felt that steatosis does not tell you anything about NASH. But remember, what makes the disease steatohepatitis is the steato part of it. Otherwise, you just have hepatitis. So we know when you resolve NASH, the steatosis always improves. When you have progression, steatosis can decrease. So it is not so great for assessing progression, but for patients with NASH, reduction in steatosis is an important surrogate for overall reduction in activity. And this is now captured in phase 2 data, where people are looking at decrease in PDFF, and the greater the loss of fat in PDFF, the more likely it is that you will actually improve steatohepatitis as well. The other thing for the long-term people look at in fibrosis is changes in HVPG. Now, what you see here are the changes in HVPG in the placebo arm of a phase 2b trial for Emricasan that we published last year. And what you can see is that there may be up to 5 millimeter change in either direction over time. So over time, there is a lot, it's quite noisy. And there are two potential explanations. Either that the technique itself has more variability than people claim it is, or that there is more biology that drives HVPG on a given day than we currently understand based on our simple approach of thinking this is a matter of flow and resistance. So when we get to measurement of outcomes in the cirrhotic population, HVPG is not quite ready for prime time. So that then brings us to the other issue is what else in cirrhosis can be used as a surrogate? Can we look at clinically significant portal hypertension? So I just talked about the issues with HVPG. But the other part is a decline in function, and we know that a decreased progression to a MELD over 15 is part of a composite clinical outcome with variceal bleeding, ascites, and encephalopathy is currently accepted both in Europe and in US by regulatory agencies as an endpoint for clinical trials. Of course, if you reverse cirrhosis, you expect these will all improve. So that is the other histological endpoint. And we will show at AASLD this year that in clinical trials, reversal of cirrhosis, even in the small number of cases that you do see, is actually associated with an improvement in survival. So these are the endpoints I think that will be very relevant, particularly for the advanced fibrosis population. Now the future is combination therapy. But combination therapy may not be applicable for everybody. You need to think about disease activity and disease stage. And that allows us to divide the patients into 4 quadrants. Those who have low activity and low fibrosis, their 10-year outcome risk is very low. And they probably don't even need pharmacological intervention right now, especially since we don't have highly effective pharmacological intervention. Those who have high activity and have no fibrosis, you can treat them primarily with a metabolic agent. You do not need combination. The targeted population for combination are those who already have a lot of activity and who already have a lot of fibrosis. And you can target some combination of metabolic or inflammation or fibrosis-related targets. But then you also have to think where the patient will end. You could improve everything, or you could improve only the fibrosis or only the activity. So depending on where the patient lands, you need to have a plan for what you're going to do next. Otherwise, your therapeutic process is going to fail. Similarly, with anti-fibrotic agents, if you reduce fibrosis, will the activity change, or will you actually be able to bring the patient back to normal? So development of combination approaches need to be tailored to population, targets, endpoints, and long-term strategies, whether it's a booster strategy, induction versus maintenance. And these are all very relevant in terms of establishing a drug development path for beyond just doing a factorial approach, looking at a standard endpoint, which is currently what the FDA is doing. So I do not believe the FDA's current approach really makes a lot of sense. So this brings us to the end. And the last message is that bypassing traditional development paradigms is a high-risk move. When we look at post-hoc analyses of early-stage studies and then create an advanced phase trial, they are at high risk of failing. So, for example, selonsertib in the first study looked very promising with small numbers of patients. But then when you went into a phase 3 trial, it completely failed. On the other hand, similarly, elafibranor, which is a PPAR alpha delta, which also in phase 2 in a post hoc analysis appeared to be effective, in phase 3 showed no efficacy, and that development has been stopped. So it is really important to do good quality early phase trials so that you either know for sure whether you're going to do okay, or if you're going to fail, fail early. So this is my rule. Decide go, no-go criteria through your drug development process. And if you're going to fail, fail quickly so that you don't waste more time, energy, resources, and put more patients at risk in the process. So this then brings us to the end. There's still a lot of work going on, and I've listed some of the ongoing phase 3 trials. So this remains a very active field, and we are fairly confident that several of these will hopefully make the cut in terms of not only the endpoint, but the benefit risk analysis needed, as I've shown you, to actually get approved for NASH. So thank you for your attention.
Okay, thank you, Arun, for your excellent talk. Very comprehensive review of the current status of the drug development for NASH. So now this talk open for discussion. So there are several questions from the online colleagues. Arun? Arun, are you online? Hi.
It's a bad time for Americans.
Yeah.
Very early in the morning. I don't blame Arun. So maybe we can. You can decide as chairperson.
In fact, we can have discussions about this MAFA, I mean, NASH. With the, you see, there is a lot of passions on trying to get some therapeutic measures, which is of use, but then there's a lot of frustrations, and especially this is becoming more and more important problems in Asia Pacific regions. Unfortunately, Arun is not here, but then we can discuss about how we should move forward in terms of the clinical trials endpoints and how we are going to handle those patients, especially in this part of the world. The definitions, say for instance, using BMI of 23, is it really applicable to the wide variations of ethnicity in Asia Pacific region? What do you think?
Yes, I think the NASH had become the most important issue in the liver diseases in the West country and maybe in Asia in the next 10 years. So, but however, most of the clinical trials for the drug development are conducted in West countries. So far there are no data available from the Asian NASH people. So in my institution, we just completed a phase 2 trial for the biopsy proven NASH patients of 90 patients allocated to receive pioglitazole 30 milligrams per day or placebo for 6 months. We do observe a similar results from, between our clinical trial and the PVEN study. So there are, even the pioglitazole have greater effects when compared to the placebo. I think that the characteristic of the NASH may be different from the Asian people and from the Western people. So even there are many phase 3 trials ongoing, and we expected that maybe 1 or 2 compound will get the both indication for NASH in West country, but I think it needs to translate the efficacy in Asia population with another study.
Really cannot agree with you more. We are on the same page. I mean, so we just cannot translate everything from the other parts of the world to Asia, and the definitions being used, and also with the new definition of MAFA, which is more inclusive, we will be including those with other comorbidities such as hepatitis B infections, hepatitis C, and also the alcoholic liver diseases into the new definitions. I'm not sure how we are going to move forward too. And unfortunately, the Arun is not here, but Professor Kanda, you are the experts in hepatitis C and the liver cancers. And what is your experience of the impact of MAFAs on hepatocellular carcinomas in Japan?
I think MAFRD has a strong impact on the natural cause of hepatitis C and HCC. And Professor Georgie, do you think is there any difference in the treatment between metabolic associated liver disease and non-alcoholic steatohepatitis?
This is very challenging. I don't think that it makes a lot of difference, because when you read the Arun's the mechanistic slides, steatosis is the primary occurrence, and then followed by the apoptosis, inflammations, and fibrosis. So I think that's the key steps is steatosis itself, the accumulations of fat, which leads to oxidative stress. And we are currently looking into how this metabolic disease, with or without co-infections with hepatitis B or hepatitis C, will respond to all the management of obesity and also diabetes and the steatosis. We have diabetic drugs which enhance glucose, urinary excretions, and also the decrease in intake of glucose from the gut. And so I think that's it is coupled with the weight reductions, which by itself the drugs actually enhance weight reductions in many instances, needs to be understood. And maybe the problem is not as complicated. If we can use should we treat those, in other words, should we treat those patients with MAFA, which satisfy the criteria proposed recently, with evidence of steatosis either by imaging or invasive techniques, plus a BMI greater than 23, that's in Asia, with MAFA, and we should treat them with diabetic medications to reduce the glucose intake or enhance its excretions to help those patients, and what would happen to the natural histories. And I think this needs to be understood.
Thank you.
Okay, there's one question from the attending. I think it's quite common in our real world practice. So may I ask George or Professor Kanda's opinions? The question is, although currently we have no any medication label for the NASH, but in our real world practice, we do have some patients with NASH and advanced fibrosis up to F4. So how do we monitor and manage the patients on NASH with advanced fibrosis or even cirrhosis from aside from lifestyle intervention and metabolic dysfunction control? So how do you manage this patient in your clinic?
In Japan, we use the fibroscan when we perform the the ultrasound, and we used the fibrotic marker. One is APRI, and another one is FIB4 index or hyaluronic acid or M2-BPGI. We also use these fibrotic marker for monitoring the fibrosis of NASH patient. How about your country?
Ming-Lung?
Oh, in Taiwan, actually, not every hospital have a fibroscan. Mm-hmm. So only in the medical center have a fibroscan, and actually we just only follow the patient with cirrhosis regularly with the abdominal sonography. But right now we try to follow the patient regularly with fibroscans because we do see the results from the previous study with a failed study with simtuzumab, although the trial is failed. But in that trial, we do see a very unexpected result for patients with fibrosis 3. The progression rate is very high. 20% of patients will progress to cirrhosis during 2 years, and 20% of the cirrhotic patients will have major liver complications during 2-year follow-up. So I think the progression rates increase in the patient with advanced fibrosis in NASH. So I think this patient population needs careful monitoring for the end-stage liver disease or hepatocellular carcinoma. And so far because we have the evidence from our phase 2 trial, we do observe the benefit of pioglitazone for the patient with NASH. So if the patients have diabetes, we will add the pioglitazone to not only control the sugar, but also we hope that the patient will have benefit from the pioglitazone in the treatment of the NASH.
I can add 2 things, Professor Ming, in the question answers. One is Nikolai has asked a question about the use of artificial intelligence. And since Arun is not here, we can say that this is a very evolving process. I'm not the moderator, so I'm just saying, but the EASL 2 weeks ago had a big project where the EASL showed this AI into it. And second is about the MEFELD and the NAFELD business. And since I was a signatory to the change from NAFELD to MEFELD, the relevance is only that it has made the field more confused. I think NAFELD was a simple term. Now we have MEFELD just to have the metabolic part included into this, and metabolic includes alcohol also, because it mild to moderate alcohol causes. To put it in very short term, the idea of MEFELD and the NAFELD thing is now more confusing. It is more now heterogeneous. It includes cryptogenic, it includes lean or normal weight, metabolically unhealthy, and it includes also people who have mild to moderate alcohol. So in my mind, therefore, we should have more debate before we accept MEFELD as a terminology. This is also not what Dr. Arun should answer it properly. And lastly, as one of the things about the new drug development and the combinations, I think one of the cheap drugs, and we have published it. I wish Arun was here. I would have asked him this question. The metformin has not only decreased portal pressure. This was a plenary presentation in ASLD. We couldn't finish writing it. It decreases portal pressure. It decreases TNF alpha. It reverses fibrosis in the second time when the biopsies were done. I think since it is a cheap drug, nobody is pushing it. So I think there is a huge scope of metformin in our treating NASH and NAFLD, especially cirrhosis. These are my comments. Over to the chair and moderators.
This is excellent, SK. In fact, in my center, we use metformin to help those patients. And many a times it's not just the improvements of the steatohepatitis is accompanied by weight reductions in those patients. And this is a cheap drugs, as just mentioned. There is a lack of drive, but I think as a physicians and academians, we should not lose the interest in those compounds because these can really help patients. A coordinated effort should be called a point two from us because the drug is not expensive and it's off patent already.
I want to make one more comment, and that is respect to the APASL and George's work. Yesterday, I was on a webinar on the AASLD, and they were all big names. I just don't want to say. You look at the hepatitis B ASLD webinar yesterday. The maximum participation went up to 70. And all the APASL webinars, I can tell you, have gone up from 150 to 300 or so. So I think APASL webinars and the COVID task force and the APASL secretariat, we have done commendable job. And I hope the new session, which will start, as well as the APASL School of Hepatology's program starting 29 September, that will include clinical signs and symptoms, is a very, very enthusiastic. And I do hope we can merge the more APASL programs and longer sessions. So with that, maybe the chairperson can conclude. We're running on the time limits. Thank you all.
Thank you, Professor Sari. So I think that time's up. I have to close this session. I would like to thank the leading of the program by Professor Sari and Professor George Lau. And also I would like to thank my moderator, Professor Kanda from Nihon University. And today I share the current status of COVID-19 in Taiwan, and hope you can stay safe in your countries. And today we also learned a lot from Dr. Arun Sanyal, from the right targets, the right population, and the expected dramatic outcome of the phase 3 clinical trial in the next few years. So we hope that we can have some breakthrough in the development of drug for the treatment of NASH in the near future. So,
excuse me, one last word at interruptions. I need to make a little announcement for the sessions next week, the coming Saturday, because this will be a memorial webinar sessions to memorize Professor Roger Williams, who passed away recently. And with the help of the Liver Institute in UK, and also the Nikolai Namoth, and with the approval of APASL, we would have a special webinar to memorize Professor Roger Williams, and the title is Roger Williams and Hepatology in Asia. And as you know, he should be one of the father of modern hepatology. And he did liver transplantations in 1966 with Professor Sir Royal Kine. and really built up the disciplines and has trained hundreds of fellows worldwide and also in Asia. So I hope that every one of you will have time to attend the sessions next week on the same times in our APASL hepatology webinar. Thank you very much.
Thank you. See you next month. See you next week. Thank you. Bye-bye.
Bye-bye.
Nice day.
I would like to take this opportunity to invite all of you to attend the APASL 2021.
Save the day.